Welcome back. So today we are going to also hear from Neanne Wedgeworth. She's the Harm Reduction Coordinator at the Missouri Department of Health and Senior Services. She actually graduated from the University of Missouri, Kansas City with her Bachelor of Health Sciences and has over 4 years of nonprofit experience providing and coordinating harm reduction services. In her current role, she supports statewide harm reduction efforts of community partners, as well as efforts within the Department of Health and Senior Services. And if y'all did not get a chance to go to their harm reduction conference earlier this year, you missed out because it was fantastic. So Neanne, I will give the floor over to you to present, and I will be here to help monitor chat and if you need any help.
Thanks, Melissa, and thank you for the shout out for the harm reduction conference. Melissa was on there as well, so really you missed her. She was wonderful. But good afternoon, everybody. As Melissa said, my name is Neanne, and I'm really, really happy to be here virtually to talk to you all about harm reduction. And I'm really excited to kind of jump in after the conversation about, talking about stigma was started. We are going to dive into a little bit of that in this presentation as well. Just to start things off with like a little bit of housekeeping stuff, please go ahead and keep yourselves muted, but please feel free to unmute yourself at any time to ask a question or make a comment. I'd really like this to be as interactive as possible. If you all are like me, I know I'm really kind of missing that in-person interaction. So as a warning, I'm going to try to take some time to ask for your all's feedback, and I'm going to do my best to keep an eye on the chat box. I know that Melissa is helping me as well. I also wanted to take a minute to acknowledge that we're going to be covering difficult topics. Drug use and harm reduction can be hard or uncomfortable to talk about for many reasons. One, because we all have different lived experiences with drug use and substance use disorder. And two, not everyone is familiar with harm reduction, or it can go against messages that we've heard about drug use our entire lives. I'm here to present this information, and when the presentation is over, the information is yours to do with it what you will. For some of us, this is going to be really old news, so thank you for bearing with me. And for some of us, it's going to be really new news, which is exciting too. But what my goal is for today is for us to show up and to show each other mutual respect, and also hopefully have some really good engaging conversation about harm reduction. As far as how we're going to be spending our time today, we're going to briefly review drug use and substance use disorder and the history of drug policy in the United States. We're going to look at national and regional HIV, hepatitis C, and overdose data, as well as the Missouri Vulnerability Assessment. We're going to discuss health equity, social determinants of health, and how those impact an individual's ability to navigate drug-related harm. Harm reduction is going to be defined and hopefully discussed. We're going to take a deeper dive into syringe services, naloxone, and medication-assisted recovery. And to close things up, we're going to talk just a little bit about person-first language and education and referrals, and hopefully answer any questions that anyone has along the way. So to start things off, every individual's drug use exists on a spectrum, right? So if we look at this spectrum, we can see two ends: abstinence and chaotic use. My substance use is on this spectrum, your substance use is on this spectrum, and we all may be on different spots on this spectrum throughout our lives. And as you can see, there's a lot of space in between those 2 points. Words that may come to mind as we're looking at this spectrum include social use, habitual use, chronic use, problematic use. Social use might be that you only smoke cigars whenever you're celebrating with friends. As far as habitual use, maybe someone stops in at the bar after work. Chronic use may be someone has continued use of substances. Problematic, something that interferes with someone's day-to-day life. And then somewhere along this spectrum, we have substance use disorder. Substance use disorder is defined as when the continued use of a substance causes significant impairment for an individual to be healthy. Substance use disorder encompasses addiction, as well as physical and psychological dependence. According to the National Institute of Drug Abuse, addiction is chronic, relapsing, complex disorder. It's characterized by compulsive drug seeking, continued use despite harmful consequences, and long-lasting changes to the brain. It's considered both a complex brain disorder and a mental illness, just like we were talking about earlier in our previous conversation with Sean. Physical dependence is when the body requires a substance to not have withdrawal symptoms. Physical withdrawal can include vomiting, diarrhea, sweating, cramps, seizures, tremor, weaknesses, and other complications. Psychological dependence is when someone's mental or emotional state is connecting to using a substance. Psychological withdrawal can include anxiety, cravings, obsessing, denial, irritability, and mood swings. And I think that, too, something about looking at this spectrum is seeing that not all drug use necessarily means that someone has substance use disorder, but there are unwanted health outcomes that can be associated with drug use generally. So before we talk about the present, I would like us to go ahead and look at substance use through a historical lens. Something that I find super interesting is, and I could talk about like historical lens of stuff like all the time. Like, so I'm going to try to really limit myself on this. You all really don't want to hear it. But something that I find super interesting is that we can see throughout history that humans have always had a relationship with drugs. But in the 1800s, we first start to see documentation of what we know today to be withdrawal symptoms provided by medical professionals. So medical professionals have started documenting withdrawal symptoms amongst patients. In 1914, the Harrison Narcotic Act was passed, which allowed governments to collect taxes on opioid and cocaine production or distribution. This also created policies that doctors could no longer prescribe opiate-based drugs. The 1920s to 1930s is known as the Prohibition era, which I think we all are somewhat familiar with, when alcohol was prohibited from 1920 until 1933, and marijuana became illegal in 1937. In the 1950s, we begin to see an increased criminalization of drug use. The Boggs Act of 1952 was what created mandatory sentences for drug offenses. So this meant that a first-time marijuana offense carried a minimum sentence of 2 to 10 years and a fine up to $20,000. The 1970s are commonly referred to as the start of the war on drugs. This led to an increase in incarceration of those with nonviolent drug charges from 50,000 in 1980 to over 400,000 by 1997. Not only did the overall number of incarcerations increase, people of color, especially Black and African Americans, were disproportionately impacted. And in the 1990s, 74% of individuals serving prison sentences for drug possession were Black, despite their accounting for only 13% of people who use drugs. And at the same time, we were starting to see this really big increase in incarceration in the 90s. We also kind of started to see this pendulum swing where their states began to legalize medical marijuana. So as like policy kind of began to shift, like to move back on that pendulum, in 2008, there was another large policy shift that reflected the kind of societal change that we had going on about how we address substance use. The Mental Health Parity and Addiction Equity Act helped regulate the health plan and health insurance industry with regard to benefits for individuals with substance use disorder and their medical histories. Even more recently, in 2016, the Comprehensive Addiction and Recovery Act provided federal legal status for many harm reduction strategies. These strategies included increased access by non-physicians to naloxone for reversing opioid overdose, and even a future amendment made it possible for federal funds to be granted to programs, for example, syringe services, in states where they were legally authorized. Current Missouri policies and programs that, here's a list of current policies and programs that provide support to people who are using drugs. Missouri has a statewide standing naloxone order. This allows for Missourians to obtain naloxone without a personal prescription from a pharmacy or other distribution point, such as a local public health agency or community-based organization. This means that as long as my local pharmacy has naloxone in stock, I can buy it or I can access naloxone at a community organization that distribute it. So for example, if I wanted to go out today and buy naloxone, I could call up my local Walgreens and say, hey, do you all have naloxone in stock? And if they do, I could walk down and purchase that naloxone without seeing a provider or having a prescription. And that's across the state of Missouri. Missouri also has a Good Samaritan law that provides legal protections during an overdose. This protection allows bystanders to seek emergency care for a person having an overdose without putting themselves or the other person at risk of arrest from drug-related criminal charges. The Good Samaritan law also covers certain other criminal or judicial offenses that may otherwise result from calling first responders to the scene. So what this would look like is in a situation where someone's experiencing an overdose, where there may also be drug paraphernalia, if that person calls for a first responder, the Good Samaritan law protects the person experiencing the overdose and the person calling from getting charged with drug paraphernalia. Missouri STR and SOR treatment programs provide access to comprehensive recovery services to people who are uninsured or underinsured. And in 2017, Missouri significantly increased access to hepatitis C treatment. The state removed liver damage requirements and doesn't have abstinence restrictions for treatment, meaning that someone doesn't have to not be using in order to get treatment for hepatitis C in the state of Missouri. This July, the state of Missouri launched Project HepCure with the goal of treating hepatitis C amongst Mo Health Net participants, which is another really exciting update. So we're going to spend a little bit of time talking about HIV and overdose. And also on these slides, if you look, there is a QR code. So if you're not familiar with QR codes, I feel like everywhere has a QR code now. But if you open up the camera on your phone and open up the camera app and place it right above the screen, the data will pop up on your phone. Will take you directly to the website if anyone is interested. As always, when we talk about data, I think it's important to keep in mind that these data reflect people, right? They reflect our friends and family and community members. So I know the data can sometimes seem cold, and data is really important, but I do want to keep that in mind as well. So HIV. HIV is a virus that attacks the body's immune system. A damaged immune system can lead to someone having an increased number of severe infections, and this is called opportunistic infections. HIV virus can live in blood, semen, vaginal fluids, and breast milk. And as it relates to drug use, HIV can be transmitted through sharing equipment that has been exposed to blood, like syringes or cottons. And using drugs may also impact a person's behavior or circumstances during sex that could leave them more vulnerable to coming into contact with HIV. According to the CDC, in 2019, there were an estimated nearly 1.2 million people who were living with HIV in the United States. And out of those 1.2 million, about 87% knew that they have HIV. In the United States, 1 in 10 new HIV diagnoses are connected to injection drug use or male-to-male sexual contact and injection drug use. And as of 2017 in Missouri, 4.9% of people who are living with HIV connected their status to injection drug use, and 4.4% connected their status to male-to-male sexual contact and injection drug use. So if we put that together, about approximately 10% of people who were living with HIV at the time of getting that HIV status or learning their status stated that they were using injection drugs. This number could also definitely be underreported based on stigma associated with drug use. And something to note as well is that 32% of people who inject drugs reported sharing syringes. And that percentage is even higher amongst young people. So 48% of people who inject drugs are ages 18 to 24 reported sharing syringes, and 44% of people ages 25 to 29. So that puts young people who are using injection drugs at and increased vulnerability for coming into contact with HIV. Hepatitis C is a virus that causes liver damage. Hepatitis C can be found in blood and is most commonly transmitted through sharing drug use equipment. Even though we may typically think of hepatitis C being transmitted through sharing syringes, like HIV, it can also be transmitted through sharing other drug use equipment that may come into contact with blood. And this just isn't limited to injecting drugs. It can also include snorting straws or pipes. It's estimated that approximately 2.4 million people in the United States are living with hepatitis C, but this number may be much higher due to underreporting. Even though hepatitis C treatment is now highly effective with very minimal side effects, hepatitis C causes more deaths in the United States than any other communicable disease, including HIV or tuberculosis. It is estimated that 32% of people who use injection drugs and are sharing equipment will receive a hepatitis C reactive test within 1 year of using injection drugs, and then 53% after 5 years. So if someone is using injection drugs, there's a 32% chance within the first year of them using injection drugs that they will get a reactive hepatitis C test, that they will end up having hepatitis C. And 53% of people using injection drugs after 5 years will have hepatitis C, statistically speaking. And as of 2018, Missouri had a reported 4,656 cases of chronic hepatitis C, and 37.2% of those cases were people under the age of 40. Nearly 804 people died since 1999 from drug overdose, and in 2019, over 7,000 drug overdose deaths occurred in the United States. The rate of overdose deaths increased over 4% from 2018 to 2019, and provisional data from the CDC from August 2019 to 2020 shows a predicted increase of 26.8% in overdose deaths across the United States. I think for those of us who work in the realm of substance use and substance use disorder, at least I knew at the start of COVID-19, I was still working in direct services. We definitely saw an increase of folks coming in who had a reoccurrence of use, so started using drugs again after a long time of not using. And a lot of services weren't available, a lot of social services weren't available, or health services. So that's something to keep in mind as we see that really, really dramatic increase in overdose deaths from August 2019 to 2020. In Missouri specifically, overall drug overdose deaths increased by nearly 17% in 2020, with a 24% increase in opioid deaths. That means in total, 1,842 people lost their lives in Missouri, which averaged about 5 deaths every day in Missouri last year. All 12 counties that had at least 15 opioid deaths in 2019 experienced an increase in opioid deaths in 2020. Clay County had the highest increase in this group, doubling their count from 15 to 30. The St. Louis Metro contained 65% of all opioid deaths statewide in 2020, which was actually down slightly from 2019. Deaths among males increased 18% compared to 13% among females. Deaths among Black people increased 30% compared to 13% among white people. And deaths with synthetic drugs, including fentanyl, increased by 34%. The Kansas City metro region experienced the largest increase in this category as it relates to synthetic drugs like fentanyl, more than doubling their count in 1 year. And then the central and southeast region both increased by more than 50% for the time period for overdoses that include synthetic drugs like fentanyl. The number of deaths with both stimulants, such as cocaine and meth, and opioids increased by 55% overall. And the central region and San Luis Metro saw an increase of more than 50%. I think that it's also important to note that stimulant overdose deaths that were just strictly stimulants also increased 25.6% last year. And once again, the QR code here does lead to the overdose data on the DHSS website. I will say that I don't think that it's updated with the most recent statistics that I just gave, but hopefully it will be soon. As far as our next, talk a little bit about the Missouri Vulnerability Assessment and what that is. The CDC conducted a county level vulnerability assessment that really talked about where there was going to be a potential outbreak of HIV or hepatitis C amongst people who injected drugs. And in the CDC identified 220 vulnerable counties in the United States. And based on that assessment, they identified 13 counties in Missouri that were more vulnerable to an HIV and hepatitis C outbreak. So, with the support of the CDC and community partners, the Department of Health and Senior Services created a Missouri specific vulnerability assessment that accounted for opioid overdose as well as bloodborne infections such as HIV, hepatitis C, and hepatitis B. The purpose of creating this assessment is to prioritize prevention and intervention efforts to counties that were identified as most vulnerable, and individual outcomes such as overdose deaths, opioid related ER visits, bloodborne infection rates, injection drug use among persons receiving substance use disorder treatment were all taken into an account when creating this vulnerability assessment. And community factors such as unemployment rates, poverty, median income, and insurance status were all used as indicators of the assessment as well. Using both of those, 22 counties were identified as more vulnerable in the categories of opioid overdose and bloodborne infection. There was also overlap in there, and there was overlap with the CDC report. I find this vulnerability assessment I found it really, really kind of enlightening and really kind of a great tool to use. And I will say that being able to really look at potentially like vulnerable counties has been really important whenever looking at like intervention and prevention. And these intervention and prevention tools are important to decrease the likelihood of a outbreak to occur, much like the Scott County, Indiana HIV outbreak from 2014 to 2015. If you all aren't familiar with that HIV outbreak, Scott County, Indiana is a rural county that experienced over 200 cases of HIV in a year time, which was really out of the norm for their county. And if you haven't read up on it, I definitely encourage it. It's super interesting to kind of look at their response and look at their prevention efforts. So whenever we're talking about drug use or substance use and substance use disorder, I think that it's essential to think of it from a place of health equity and keep in mind those social determinants of health. And I feel like we really talk about those social determinants of health quite a bit. Health equity means that all people are able to be their healthiest selves, no matter their identity or circumstances. And health disparities are differences in those outcomes that are avoidable, unfair, or unjust. Social determinants of health are economic and social conditions that impact individual and community health. This can include physical characteristics of the neighborhood a person lives in, access to healthy food, safe housing, quality education, and economic well-being. And I know based on previous conversations that I've had, when we're thinking about rural communities too, is thinking about a social determinant of health may be access to transportation to get to the health and social services that are needed. On this next slide, we're just looking at this social ecological model that includes multiple levels of physical and social environments that interact and overlap to impact health. So I want to really look at this through the lens of how this impacts how people are able to navigate drug-related harms, how people are able to navigate having substance use disorder. There's no single factor on here that may lead to a person to use or misuse substances, but this model does show how different intersections of an individual's life could impact how they're able to navigate substance use disorder. When we think of individual factors, that's things like your circumstances or your experience. This could be childhood trauma, a person experiences overall mental health, or knowledge of harm reduction practices. I think an example that I experienced of this was I was providing testing services to an individual whose understanding of hepatitis C was that you could give it to yourself. And that's something they'd always experienced. And that's something that that's a thought that they'd always had and a belief they'd always had, which is a really common thing that we experience when we're working in hepatitis prevention. And so their thought process was, well, why would they need to change the way that they were using if they already were going to get hepatitis C because they were going to give it to themselves. And so I was able to have a conversation with them wherever we were able to increase their knowledge of harm reduction practices, such as, one, hepatitis C has to come from somebody else's body, but two, there are things that we can do to reduce the risk that you're going to come into contact with hepatitis C, like not sharing syringes or not sharing different drug use equipment. So that could be an example of an individual factor that impacts how someone is able, if someone is going to, if someone's going to be diagnosed with hepatitis C or not, or come into contact with hepatitis C. Interpersonal or relationships is how you interact with your friends, family, and peers. This includes how someone's family may feel about medication-assisted recovery, if themselves or their family know how to use naloxone, or if their peers have an understanding of drug use. Community factors look like where you live and what you have access to. This could include, do you have access to comprehensive health services? Are there social service agencies around you that can address your needs, such as food and housing? This could also include questions of, are there culturally reflective recovery services available in the area that you live? Societal issues are things like stigma surrounding people who use drugs, accessibility and quality of health insurance, also legislation that supports different health and social services. So whenever we're thinking about this socio-ecological model in substance use, and specifically in rural communities, does somebody want to unmute themselves and kind of share how they've seen these different factors impact need to access substance use disorder services? I'm also going to take a minute to take a drink of water so someone could think.
Yeah, and I know you people are not shy.
We can definitely come back to it at the end, so just be thinking about this. And as we had previously talked, I think we talked enough about this earlier to really understand how, stigma is a barrier that very commonly having conversations about stigma, and how that impacts people accessing substance use services or accessing social services to navigate drug-related harms. So what is harm reduction? The Harm Reduction Coalition defines harm reduction as a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Also, a movement for people who use drugs. But for a second, let's go ahead and think about harm reduction outside of drug use. Sunscreen is a great form of harm reduction. Seatbelts are another great form of harm reduction, because we acknowledge that there can be risk associated with going out in the sun or getting in the car, but we give people tools that they can use to remain healthy and safe when they're out in the sun or driving down the road. Harm reduction is also applied to legal substances such as nicotine or alcohol. I think a great example of a harm reduction strategy is if people are going out to a bar, then they have a designated driver, so someone who's not going to drink, and get them home. Um, Another thing with like nicotine harm reduction may be that someone uses a nicotine patch to reduce the amount that they're smoking. And a lot of the time when you hear about harm reduction, you'll hear the phrase that is meeting people where they're at. And what this allows us to do is to provide care, services, and support change no matter where someone is on that substance use spectrum. Using harm reduction based strategies allows us to really give a focus to tertiary prevention, meaning we are looking at someone's drug use through the lens of reducing unwanted health outcomes or even death while they are using. The following are some of the values and principles that support harm reduction work. And I think that even if you aren't doing work that is traditionally thought of as harm reduction, that these values and principles are generally important for all health and social service providers, such as centering the client, centering people who use drugs, valuing community and individual well-being, really putting an emphasis on health and safety. Harm reduction is also realistic, empowering, evidence-based, and intersectional, meaning we're not just looking at drug use, but we're looking at their whole picture of health. The following are some examples of harm reduction services. We have things listed here that are typically thought of as harm reduction, such as syringe services or naloxone distribution, but there are other harm reduction based services that meet people where they're at, such as PrEP, which for those who may not be familiar, PrEP is like a birth control only for HIV, condom access, and hepatitis C and HIV testing. And I will say too that this isn't like the be all end all list of harm reduction services. There may be things that aren't on here that should be. Um, there may also be things on here that you're like, wow, like I don't really think that that is harm reduction, and that's okay. This is just things that may be services that may be based on harm reduction or provide health and safety for people who are using drugs. So now we're going to take some time to dive in a little bit deeper to a couple of these harm reduction based services. The first one that we're going to talk about is syringe service programs or syringe access programs. You may have also heard needle exchange programs. Nearly 30 years of research shows us that comprehensive syringe service programs are safe, effective, and an evidence-based practices. These services do not increase illegal drug use or crime and play an important role in reducing the transmission of viral hepatitis, HIV, and other infections. Syringe service programs are also not limited to distributing safer use materials. They can also distribute naloxone, condom kits, educational materials, and other items that are reflective of the needs of their community and participants. This could be something like distributing hot meals, or this could be education about abscesses and wound care and other bacterial infections that people may be experiencing, bottles of water, or different hygiene items. And a lot of the time, there's a large focus on syringes or syringe distribution, which is an important piece of syringe services. But as I mentioned, it's not the only piece. Syringe service programs are a space for people who are using drugs to gain access to tools that meets their health needs. And listed here, we do have some examples of services that could be offered on site at a syringe service program, or it could be a referral that syringe service provides. For example, here we do have that HIV and hepatitis C testing could be offered at a brick and mortar location of a syringe service program or in an outreach setting. They could also have connections to local substance use disorder treatment services to provide referrals to participants who are ready to engage in treatment. And during COVID-19, I've heard a lot of really amazing stories about how some programs have been able to expand services to include masks, hand sanitizer, water, that program participants may no longer be able, that were potentially not able to access during shutdown. This also includes that I've had conversations with some programs who are able to offer COVID-19 testing as well as access to vaccinations. Outcomes of syringe service programs in communities, according to the CDC, include the following. Syringe services decrease the rates of injection drug use in communities. In fact, new users of syringe service programs are 5 times as likely to enter drug treatment as those who don't use the programs. And people who use syringe service programs are 3 times more likely to stop injecting drugs altogether. Syringe service programs decrease overdose by providing overdose education and naloxone distribution to people who are actively using drugs. They are associated with a 50% decline in the risk of HIV and hepatitis C transmission. Individual health, but syringe services focus on community health by protecting the public and first reducing the presence of needles in the community with no increase in crime. Finally, they are cost effective. The estimated lifetime cost of treating one person living with HIV is more than $450,000. Hospitalizations in the US for substance use related infections cost over $700 million each year. And so syringe services are able to reduce these costs by decreasing HIV transmission, decreasing overdose, and linking people to other health services, such as abscess and wound care, before it becomes a medical emergency. Does anyone have any questions? Okay. So we are going to now do a little bit of a naloxone overview. Naloxone is a non-addictive life-saving medication that can reverse the effects of an opioid overdose, including an overdose that involves fentanyl. Recognized by the CDC as an evidence-based strategy for preventing opioid overdose death. When naloxone and overdose education are available to community members, overdose death rates decrease in those communities. As previously mentioned, Missouri does have a Good Samaritan law, as well as a standing order. And that standing order is when people can access naloxone without a prescription. And as mentioned, the more people who have naloxone, the less overdose death in those communities. But there are certain folks who are at an increased vulnerability for experiencing an overdose. This includes people who may be misusing opioids, as well as those who have had a period of time of not using. This could include times of leaving a treatment facility. This could be post-hospitalization or release from incarceration. And that's because opioid tolerance can be completely diminished in 3 to 7 days. So if someone, for example, is released from incarceration and they use the same amount of drug that they were previously using, that could cause someone to have an overdose. We also know from the data that we discussed earlier that overdose deaths are increasing not only among people who are using opioids, but amongst people who are using stimulants as well. Naloxone distribution to people who are using stimulants is increasingly important with the increase of opioids like fentanyl and stimulants such as meth and cocaine. Stimulant overdoses are commonly referred to as overamping. And even though these cannot be reversed by naloxone, there are harm reduction strategies that can be used to decrease the likelihood of overamping. And there can be discussions had about what an overamping response looks like in a medical emergency. I will say too that if you or your organization is interested in learning more about overamping, Missouri Institute of Mental Health is hosting a stimulant overamping education training with multiple day options in August and September. I think especially in as a person from a rural community, I remember having conversations about prevention and drug use. And I felt like sometimes that stimulant response was really left out of this conversation. So it is really exciting to see um, an increase awareness of stimulants and stimulant overamping and how to best keep people who are using stimulants safe. And now we're going to talk a little bit about medication assisted recovery. Um, just as we mentioned earlier, it's also called MAT. Medications typically associated with MAT are methadone, buprenorphine, and naltrexone. These medications are prescribed to stabilize a person's physical dependency, aka minimize someone's withdrawals. This stability can provide the support to individuals needed to achieve healthy social, psychological, and lifestyle changes. And according to the CDC, numerous studies have shown that MAT contributes to significant reductions in opioid use, criminal activity, and overdose. Numerous studies have also shown that access to medication improves patient survival, retention and treatment, and birth outcomes of those with substance use disorder who are pregnant. I know this is a lot of different information, a lot of just overall information. So I really want to finish things up by talking about a few action steps to kind of to consider. The first thing is working on person first language. Even without realizing it, the language that we use can be super stigmatizing. And also the words that we use, especially if we're providing services, can really shame folks who are using drugs. And I know that at least when providing direct services, that trust is so important to be able to having those conversations. So even if it's things that we don't necessarily we've never thought about before, um, things like calling a drug test clean or dirty, not only can this be stigmatizing, but at least what I've found is that it's a lot easier to have conversations with folks if I'm specifically talking about what I'm talking about. So, for example, if someone tells me, "Oh, well, that test is clean," I may not know what that means, but if I talk to someone and be like, "Okay, well, that was a non-reactive hepatitis C test," that makes a lot more sense to me, and that's a lot more clear for the person that I'm providing services for. And here we do have a graph of words that are commonly used that may be stigmatized or stigmatizing. And here are some replacement words. I will also share a website link that I have in the chat whenever I hop off here that has a very large person first language chart for everybody to access in case anyone is curious. And then another thing that we can do is include harm reduction based education referrals and also think about how we're linking people to care. Um, I know when providing referrals, a lot of the times, I would try to think about like, is this referral accessible? Is it a quality referral? And is it relevant to someone's life? So, for example, whenever, we think about harm reduction education is really meeting the educational needs of folks that we're serving. So, for example, kind of to bring it back to opioids and stimulants, if a majority of the people that I'm using that are using my services or that I'm providing services to are really stimulant focused, like if stimulants are more of their drug of choice, then having only opioid based information may not meet their needs, may not meet them where they're at. Um, Also thinking about referrals that may or may not include recovery services. For example, I've know that I've provided referrals for housing before, and previously to really thinking about this, I would just do whatever housing referral was available. But there were some folks who either specifically did not want recovery based housing for whatever reason. Maybe they weren't ready to engage in any kind of treatment, or maybe they had had negative experiences with recovery based housing before. But I learned how important it was to have other options if available in my community of housing specifically that maybe wasn't recovery based, but then also having options for people who are specifically wanting recovery based housing. So with that, here are some Missouri specific referrals and information. This is a list of that Missouri vulnerability assessment, different Hep C information. This is also our harm reduction safer use website that does have a lot of referrals to different information available. We also do have the DMH's Substance Use Disorder and Recovery Service Navigator on here. Here's information for people who use drugs. So what that looks like is we do have a safer use PDF that kind of walks people through safer use strategies. There's also the Harm Reduction Coalition Safer Use Manual and HIV and hepatitis C prevention information. We do have some national referrals, such as hotlines. One that I'd really like to draw attention to that people may or may not know about is the Never Use Alone hotline. So what that is, if someone is unable to use with someone else, which would increase their risk of experiencing a fatal overdose, they can call this hotline and a provider will stay with them on the phone. And if they're non-responsive, they'll call for emergency services to come and check on that person.